Welcome to Leicester. We turned the sun on for you as well. I hope you've seen this. Hopefully, maybe while you're here, you may have time to see some of the dazzling industrial Victorian architecture that we pride ourselves on in this area. So have a look around as well. But thanks, Bex, and thanks for the invitation to talk. So this is going to be a bit of a back to basics talk. So we're going to talk a little bit about what SCAD is, what we know about it, if you like, now that we're in 2023. So back to the very beginning. The heart, of course, is a muscle, and the heart's job is to pump blood around the body. But because the heart's a muscle, it needs its own blood supply, and that blood supply comes from the coronary arteries. And they're, if you like, my day and sometimes my night job. These coronary arteries, they emerge just above the aortic valve, just outside the heart, and then they beetle across the surface of the heart and plug into the heart muscle from the outside. And hopefully you can see them, what they look a little bit like on here. And it's these coronary arteries where the problem arises in SCAD. So the first thing to say with what is SCAD is that it is a different condition to the causes of conventional heart attacks. And that's, if you like, the most important statement of all. Most heart attacks are caused by this condition that we call atherosclerosis, because it's a bit of a mouthful, which is all to do with the altered fats and cholesterol and inflammation in the wall of the artery, and then clots that form inside the arteries, and that's why we call it coronary thrombosis. SCAD is totally different. Those arteries we were talking about, they're tubes taking blood to the heart muscle. But our arteries are under blood pressure. They're pressurized tubes. And so they actually have a layer of muscle cells that goes around the outside of them, because if your arteries were paper thin, humanity would not exist, right? So it's actually within the wall of the artery, within these muscle cells, that the problem develops in SCAD. And what happens is a spontaneous bruise or bleed occurs within that wall. And like any bruise in your body, if you've ever had a bruise on your, on your elbow, on your shin, if you've ever had one of these bruises, you'll realize that they get pressurized, don't they? They feel tight and tense and pressured. And that's exactly what's happening in the wall of the artery. As this little bruise builds up, it pressurizes. And as it pressurizes, it actually squashes the artery where the blood should be flowing from the outside. It squashes it down. I sometimes say it's a bit, if you think of it a bit like a car tire, where my hands are coming out towards you. I haven't got enough hands here. But if you've got the blood flowing down the middle and the wall of muscle cells, the bruise is in the wall, and as it pressurizes, it squashes the artery down from the outside. It's like an external compression. And what you can see here is the consequence of that. These black lines here are what the coronary arteries look like when you put a little bit of X-ray contrast in them. But where the white arrows are is the consequence of it. You can't see the bruise here because it's in the wall of the artery. You have to imagine that bruise is wrapping around the outside, squashing the artery down. And that's what leads to this narrowing. And because it becomes narrow, not enough blood and oxygen gets to the heart muscle. And that's what causes the pain and the injury to the heart muscle in SCAD. What you're looking at here is where the artery's being sort of sliced end on, if you think about it like that. And this is a laser light imaging catheter, which we call an OCT catheter, taking a picture from the inside of the artery. And this here is where the blood should be flowing down the middle, if you like, the middle of the wheel. And this thing here, the sort of moon-shaped thing around the outside, is the bruise in the wall of the artery that's squashing down, compressing this. So this should be out here, but it's been squashed right in on itself. And that's the reason that not enough blood gets to the heart. And this is what it looks like when you build all of this up. So this is what, at the top here, is what you're seeing on the angiogram with the narrowing. You can see the big bit at the end, and then it narrows right down. And what the black is the bruise in the wall of the artery that's wrapping around the outside and squashing the artery down and causing all of the trouble. So this is roughly what we think is happening, and I'll talk a little bit about how we understand this, which is a consequence of some of the research that's been done here in Leicester. This is what we think is happening. So we know that little tiny blood vessels come from the place where the blood is flowing and go across the wall of the artery and outside sometimes into the bits just outside the wall, little tiny microvessels. And we think it's disruption of one of these vessels that leads to this bleed and then bruise developing. And then as that builds up and pressurizes, it squashes the place where the blood should be flowing, which we call the lumen. And sometimes, so that bruise will, as it pressurizes, it will also track. This is the bit where I need more hands. It's moving along on the wall of the artery as well. And this is sometimes the bit that, so people sometimes call it a tear rather than a bruise. And sometimes people say, well, have I had a tear or have I had a bruise? And they're just ways of describing the same thing. Because as that bruise tracks along in the wall of the artery, it's separating those muscle cells out. And some people will call that a tear. Sometimes also when it gets under high pressure, this is just a few cells, this little bit between the bruise and where the blood should be flowing. And sometimes it can actually just pop through like that, so that there's actually a connection now between where the blood should be flowing and the bruise in the wall of the artery. And so sometimes you can see two channels where the blood is flowing. And we think this probably happens because of the pressurization, that it actually bursts through into where the blood should be flowing. And that's why you get this appearance. So there are various things that you can call a tear. I often don't call things tears because tears sound a bit terrible to me, whereas bruises heal. And that's what happens to the bruise in the wall of a coronary artery. And that's what happens in SCAD. So how common is SCAD? Well, it's not rare, is it, looking around you? And, you know, part of this journey that we've been on is about the fact that we're now recognizing that this is not a rare condition. There's actually quite a lot more of it out there than perhaps we maybe thought about back when I had long black curly hair down to my waist. And those days are long gone, sadly. In terms of the numbers, I think we're going to see between the clinics at least 400 new patients with SCAD this year in the UK. I still think that's probably the tip of the iceberg. We're probably working our way down the iceberg. But, you know, at the moment, things are based in Leicester, London and Scotland, and that's still a long way for some people to travel. And, you know, we're aware of that and the cost of coming to the SCAD clinic and things like that. So I think there's probably 3 or 4 times at least the number that we're actually seeing that are out there that are not necessarily getting that specialist clinical care. So if you put it in a different way, I think there's probably something like 4 or 5 SCADs happening every day in the UK, which is something to think about, isn't it? So you've seen this picture, but I use this when I'm talking to doctors to, instead of a table of demographics, to say who gets SCAD. Well, you can see that it's a disease that's overwhelmingly of young to middle-aged women. Also, there are some critically important men, and they are very important, not just because we want to look after everybody, but because they are not influenced by the same hormone environment as our female patients. And that makes them particularly interesting and important from a research perspective for us to understand. So mostly a disease of young to middle-aged women. About 8 to 10% are male, and about the same percentage happen in and around the time of pregnancy. And as you can see from this work, which is again some work that we've done with international partners, but shows you about the association with pregnancy. And one of the things we learnt in that study is that this is disease mostly that happens after delivery of a baby rather than during pregnancy. If it happens in pregnancy, often it's later in pregnancy, not always, but often, and in those months after delivery of a baby. So this is a very unusual and interesting and important disease. I sometimes say, can you think of any other disease that doesn't involve things which are unique to women that has a 90% female sex predominance? Because I can't. And there must be a reason for that. And that's, again, one of the focuses of research that we're very interested in trying to understand. So how do patients with SCAD present? Generally speaking, they present with symptoms typical of heart attacks, but one of the things that we're often putting out in our conversations that we have with our first responder teams is that heart attacks can present a little differently in women in terms of the symptom description. It can be that thing that you see on the television, but actually it can be quite variable in terms of exactly where the symptoms are, where they go, and how people feel. So it's often typical, but having a little bit of a broad index of suspicion is important as well. One of the other things which can be helpful, and this can be helpful, we can talk about post-SCAD chest pain, I'm sure we will at some point during the day, but it can be helpful working out what's important and what's not important in terms of chest pain, is the non-pain symptoms. SCAD is often associated with feeling really unwell. Something bad is going on, feeling sweaty, clammy, nauseous. And sometimes these other things can help. It's not the same, these things are not necessarily true for everyone, but they can be helpful for some people. It's usually sudden onset. Sometimes you might get a prodrome of a few days, but it's not, generally speaking, a condition that builds up over, 6 months or something. It's usually something that's happening there and then. Serious heart rhythm disturbances are uncommon. They do happen. There will be a small number of you who will have had that experience, but they are uncommon. So how is SCAD diagnosed? Well, top of the list, and the thing for, this is not an audience of healthcare professionals, but they might watch the video. And if they are watching the video, it's really important to talk to the patient, because the story is a very important aspect, and we call that history in medicine. The other thing is the ECG, and this is so sometimes people get confused when they get told that they've had STEMI or NSTEMI or one of these things and what those things are. Those terms are all about what the ECG looks like. So when you get this thing that goes up like that, that's called a STEMI, ST elevation, because this is the S and this is the T wave, and it's up, it's elevated. And MSTEMI is when that's absent. Don't worry, I'm not going to test you at the end of the day on your ECG knowledge, but it's just because it's a question people sometimes ask. And the other thing is the troponin, and this is one of the reasons that we're all here, is that this blood test, the troponin, has become much more sensitive these days. And it's a really good tool, because if, SCAD outside the context of a raised high sensitivity troponin is incredibly uncommon, like vanishingly uncommon. And in that context, it's usually when it's happened some days ago. And so when we're just missing the troponin, it's not that it wasn't raised, it just isn't raised at this moment. But pretty much invariably, the troponin is elevated. And this helps too, because again, if you happen to go to hospital because you're having chest pain and you're worried about it, if the troponin is normal, that is not SCAD, and that is a reassuring thing on the whole. So it's what the patient says, it's that ECG, and it's the troponin. Those are the key things, really. And then the next step, generally speaking, is an angiogram. And again, many of you will have the little scar on the wrist, or maybe down in the leg area, to show that you've had that process. So SCAD mostly has quite typical appearances on the angiogram, and that's something for the clinicians to find out. And sometimes we looked at that OCT image. Do you remember the bright orange thing that I was talking about earlier? Sometimes they'll use those extra special imaging tools to help to make the diagnosis where there's some uncertainty. So again, I'm not really going to go through all of the specifics of the different things that we use to try to identify SCAD. Essentially, it's about those narrowings of those coronary arteries and how they look and where they are. So for example, this artery that comes straight down the page here, the left anterior descending coronary artery, or LAD, sometimes people call it, is the most commonly affected artery in SCAD. It seems to be more affected than any others. We don't really understand why. And then there are particular things. So SCAD often doesn't affect the very upstream vessels. It tends to be more downstream, which is one of the reasons it generally causes small heart injuries. So there are things that we use to teach our cardiology colleagues, and also to help us to work out what is SCAD and what isn't SCAD. And again, here's some more orange pictures for you. By the end of today, you'll all be cardiologists, and I'm hoping that you'll all set up SCAD clinics around. No. But just to show that there are these tools which will help you to recognize them. The OCT is the bright one, that's laser light, and the more grey version is something called IVUS, which is intravascular ultrasound, which you use to measure from the inside. So one of the things we've been doing very recently in the research is looking at angiograms, which is the process that we looked at just in a moment, where we're taking the pictures of the arteries from the inside using the little tubes that we float up from the wrist artery or the leg artery, versus CT scans. And what we're finding is that CT scans at the moment, in terms of how they're configured, are not brilliant at diagnosing SCAD. So they tend to miss quite a lot of patients, and that's because CT scans have a lower spatial resolution, so you can't see as small things with CT as you can with angiograms. And we are starting to work. So at the bottom there, the thing called the phi score is a very new technique, which is where we're able to use bits of the CT scan to look at inflammation around the artery. And we know that the bruise around the wall of the artery causes inflammation while it heals. And so this is something that we're starting to look at to see whether there might be a route in the future, not yet, that may allow us to be able to use CT scans to make the diagnosis non-invasively, so you don't have to have the angiogram, and some people get sore arm and all of those bits that go along with having an angiogram. So that's how it's diagnosed. It's also important to recognise, and this is one of the important things that we do in the SCAD clinic, that diagnosis can sometimes be tricky. And sometimes we have to spend a bit of time figuring things out and trying to work out, is this SCAD or is this one of the other things? And some of you may have gone through that experience or even be going through that experience in the clinic, where we say when we need some more tests or we need some more scans in order to get to the bottom of trying to work this out. And again, also this is a process of educating medical professionals who are out there. It's easier to some extent for me to look at an angiogram and say, I think that's SCAD, because I look at loads and loads of SCAD angiograms, and it's kind of what I do. Whereas other people in other centres may only see, a small number in their careers, or, in a year they'll see very few. And so again, we're trying to say, this is what it looks like, this isn't what it looks like, and try to help people. That's another thing that we do a lot of. So how is SCAD treated? Should we be using stents, balloons, or nothing at all? And I think the most important thing to understand here is that that does vary from person to person. So if you've had stents, that's not necessarily a bad thing, and I'll come on to the reason why in a moment. We do know, and this is important, that if it's left to its own devices, SCAD pretty much invariably heals. It's a bruise, and if you leave that bruise for a period of time, it will reabsorb and your leg will go back to normal. Exactly the same thing is happening within the wall of the artery. Little vessels go in and they reabsorb the bruise, and that squashed artery re-expands, and that's what you can see here. There's a really long SCAD causing a narrowing from about here to here. Can you see that? So it's from about there to about there, a really long narrowing. You've got that? So you're all cardiologists, I told you you were. And if you look at the left-hand image, you can hopefully see that that's now much bigger again. And that's just the passage of time, because that bruise has healed up and the artery essentially has gone back to normal. Sometimes people ask the question, they say, well, how do I know it's healed? Because you want to know it's healed, don't you? And the reason that you know it's healed is because back in the old days, when I was the rock star, we used to go take people back and do an angiogram again and have another look to see if it had healed or not. And what we found is that it had always healed. So it had pretty much, when we looked again, it all looked fine, like here. But sometimes, we made things worse with all of the tubes and catheters and things. And so these days, we don't go back and have another look. We sometimes use CT scans if the SCAD was in a particular place or particularly extensive and we just want to check things. But often we just leave it alone because we know from experience that it has healed, and that actually sometimes the looking can make things worse. So what about these stents? Don't worry, I'm not going to go through all of this data in huge detail, but this is a paper that was published from the research, and what it shows is essentially that those patients who have stents for SCAD are generally different to those that don't. And they're different in that often the artery is blocked, which is not that common in SCAD. Usually it's like the angiogram we just looked at, where there's a long narrowing. But sometimes they'll have it will be blocked. They might have that ST elevation, so the slightly more worrying looking ECG. So there will be reasons for the stents. That sometimes if you have a completely blocked artery, we have to do something to open that artery up and make you well again. So I think sometimes people who've had stents can be worried that when you read online or look at the online things that we say we prefer conservative management, the answer is we do prefer conservative management if we can, but there will always be some patients in whom we do need to reach for balloons or stents. And so it's important to understand that. Also from this paper, important to understand that those patients who have had stents and those patients who have not, both do really, really well. So this is probably shows both the reason why we try not to do stenting where we can, but also why we need to in some people. So the graph over on panel B shows that the trouble with putting stents in is that you do sometimes get complications that arise, and that's more common than stenting for other types of heart coronary problems. But the red graph, what's that showing you, is that essentially when you put stents in, when you need to put stents in, what you're seeing is improvements in flow. So TIMI is a measurement of flow. So basically the more left your column is, the more flow you're getting in the artery, and obviously getting blood flow back in the artery is important. So what this is showing is that for most people, we want to try and manage without stents, but for some people, stents are necessary and that they do benefit you in terms of improving flow, which is what helps the heart to recover. So we do know, and to some extent it's a little mini elephant in the room, that SCAD can happen again. It's actually not that common, okay? Around 10% of patients will have a recurrence over a 5 to 10 year follow-up period. Recurrences can occur, so there will be a small number of people who've had more than 2 events. It can happen. Flip that on its head though, and that means that 90% of people are not getting a recurrence over that same time frame. So as you're all glass half full people, that's the way that you're going to be thinking about it. You're 9 times more likely not to have a recurrence than you are to have another recurrence. But also, we know that the prognosis from SCAD, that's how you do in the long term, is excellent. And the reason is it generally causes small injuries to the heart muscle. And so even patients who've been unlucky and had more than 1 event, generally speaking, the combined injury to the heart is on the smaller side and means that they can still be well and be managed and not have symptoms and do okay. So I know that there'll be some people in the room who have had recurrences. We recognise that that's a real important focus of the research, okay? But I think for most people it's important to understand that yes, it happens, it's not that common, and even if it does happen to you, you will do really well. So what about tablets? Well, what we really need here is data. And what we need to get the best data are clinical trials. And I'm very excited that this is the first SCAD conference where I've stood up and been able to say that that process has begun. So the first clinical trial has started recruiting in Spain, and is recruiting very well. The far-sighted Spanish Cardiac Society donated €1 million to this clinical trial. But the important thing, we helped and supported the design of that study, and I think it's going to be probably the first that will start to give us some real data to answer the question. We are also in the process of trying to do an even bigger study focused on the aspirin or not question, the combined antiplatelet therapy, that's your ticagrelor, your clopidogrel, prasugrel, all those, and trying to work out whether they are a good thing, a bad thing, or don't make much odds. And again, that will take a while because we have to, these studies will be international, involve many sites and many patients like yourselves. But what we hope is that in time, I'll be able to stand up here and instead of waffling vaguely, actually say, this is the medication that we need you to be on. Important to understand that tablet treatments are individualized. Different people are different. And so when you look online and it says, well, I think you should be on this or you shouldn't be on that or those kind of things, you may be slightly different. There may be slightly different contexts. So, for example, patients with stents will need an antiplatelet drug. So lots of conservatively managed SCADs may be managed at the moment without them, but if you've got a stent, you need it because it stops that stent from clotting off. Patients, and there will be some who have a larger scar on the heart, tend to need a little bit more medication just to protect the heart and just in the context of having that scar, just to keep the heart from getting any bigger. Medication is very good at keeping the heart nice and small and doing its job. So I think my message, we can talk about specifics of tablets, but I wanted to get the message across that not everybody is the same. You can look next year, everybody is different and everybody potentially needs slightly different treatments. As we've said, the role of these antiplatelet medications, these are aspirin and aspirin-like drugs, is a little unclear, particularly in those patients, specifically in those patients who don't have stents. Our practice at the moment is that we tend to want you to be on as little as we think is right. So we don't put everybody on aspirin just because, well, it's there and we use it for other things, so let's just give it to everybody. We try to work out, a logical reason to continue it or discontinue it. In terms of beta blockers, there is a single observational study which suggests two things, and these two things are independent of each other. The first is that good blood pressure control is important. Now, many SCAD patients have low or not very high blood pressures. And so clearly lots of blood pressure medication will just make you feel dizzy. So it's not, again, for everybody, but some SCAD patients will have high blood pressure, and that's something that's now coming out of the studies, that association between SCAD and high blood pressure. And if you do have high blood pressure, we want your blood pressure to be well controlled, not just controlled, but well controlled, well down within the normal range. So the second thing in that observational study, an observational study is different from a clinical trial. Clinical trial, we're all, it's all done randomly and we don't know who's got what and all of those kind of things. In observational studies, we just observe people and we see what happens to them. And then we look backwards and we say, what tablets were they taking? So in that observational study, the use of beta blockers was independently associated with a lower risk of recurrence. It seemed to be associated with patients who had fewer recurrences. And that's the reason that we try and hang on to a bit of beta blocker in patients after SCAD if we can. Now, we have to recognise that some people are not able to tolerate beta blockers. This is not a disaster. This is just reality, okay? And so again, it's all about individualised treatment. If we can manage a little bit of beta blocker, we do. But if we can't, we're not in the business of, making you so fatigued that you can't get up in the morning. That's not what it's about. So we have to get the balance right. But that's the reason why we try and hang on to a bit of beta blocker if we can. Statins, again, for the most part, we have nothing at the moment that suggests there's a link between SCAD and circulating cholesterol levels. Unlike that conventional coronary artery disease where the benefits of statins have been very clearly demonstrated. So for us, statins tend to be for selective patients, but there will be some people who we think a statin is a good idea. Some of those patients, it may be if there's a lot of stenting, that we might be worried over the course of 30 years whether that might increase the risk of furring up. We don't really know that, but we sometimes hang on to a statin in that context. People with bypass grafts, particularly vein grafts, as a consequence of their SCAD. Again, we want to protect those bypass grafts and we might go with a statin in that context. And then there's some people who have a stonking cholesterol. And if you like, it's just the same as if you hadn't had your SCAD at all. It's just the same as if you went to your GP and your cholesterol was, there was enough cholesterol in your blood to be able to sort of put cream on the milk or whatever it is, then, you might need to have a statin. So for most people, we are looking to back away with statins. But again, if you're one of those people that is on it, there may be a good reason why. And yes, as I said at the bottom there will be other medications that different people are on. Again, with post-SCAD chest pain, we sometimes try medications, but it will be different and individualised. So cardiac rehabilitation exercise is going to be a separate talk and discussion about that. All I wanted to say was cardiac rehabilitation, yes, 3 yeses, okay? And then in terms of exercise, there are some sensible limits around the edges of the more extreme things, and we'll talk a bit about that. But we want you to get back to the things that you enjoy as much as possible, because that's an important aspect of psychological recovery from SCAD and good heart health. We sometimes say that exercise is good for the heart, good for the head. And so we encourage it, but maybe turning into Muhammad Ali is not the best option, perhaps. So the other thing many of you will be discovering after you've had your SCAD is that we like to look at all of the other arteries in the body. The reason for that is that SCAD is associated with some variations and abnormalities of the arteries elsewhere in the body. These include the rather lengthily termed fibromuscular dysplasia, which does sound almost as horrifying as spontaneous coronary artery dissection, doesn't it? Fibromuscular dysplasia is commonly found in SCAD patients. In some studies, 100% of patients they think they can find it in. I think they've got very good eyesight. But certainly a third to a half of patients will have it. It's where the arteries, they look like they've got a sequential dilation and narrowing in them. FMD is found in lots of patients. It causes problems in very few. And that's the most important message. So if you come back and your scan has got fibromuscular dysplasia on it, this is not a disaster. Sometimes that spontaneous coronary artery dissection fibromuscular dysplasia thing sounds so enormously long that it must be catastrophic, but in fact it is not, okay? Sometimes we will find things that we need to keep an eye on over time. Little aneurysms, little swellings of the arteries, dissections in other arteries, we may need to keep those things under surveillance and make sure that they don't change. The main thing is we need to get these things looked at. So contraception, pregnancy and HRT, and these are critical things that we talk about in the SCAD clinic, and I will do a little bit of a mini overview now, and we can also discuss things further in the clinic. Importantly, for women of childbearing age, there are some medications which we sometimes give patients who have heart disease which can be damaging to a developing baby. An example is those ACE inhibitors, the things that end in pril, like ramipril, for example. And so if you are contemplating a future pregnancy or are in an environment where that could occur by accident, it is a good idea to discuss this either with your SCAD specialist or your cardiologist or your GP. And if you are planning a pregnancy, again, it is a good idea to just talk about that in advance. Pregnancies after SCAD are not, generally speaking, banned, but there are things we need to talk about. So, for example, the risk of recurrent SCAD occurring during a subsequent pregnancy is something we would need to talk through. It doesn't mean that it's, as I say, banned, but it's something that we would like to make sure that you are fully informed about. In terms of contraception, generally, if hormonal contraception is needed, we prefer that to be progesterone-based. Now, these days, there are lots of different routes by which that could be administered, whether it's a pill or a patch or a coil or different types of things, but progesterone-based rather than estrogen-based. And in terms of HRT, more data is needed. We have to recognise the fact that we would, like to be able to answer this question with certainty. At the moment, we don't have all of that data. HRT does get a bad press in SCAD. It sometimes gets a bad press anyway. It's one of those things, isn't it, that sort of lights up in the media sometimes. The main reason HRT gets a bad press in SCAD is because this is a condition which has a high female sex predominance and is a perimenopausal and postpartum disease, and so it's likely that this has some link to female sex hormones. The studies that we have don't show an increased risk of SCAD recurrence in patients who are taking HRT. As yet, data is incomplete. They also don't show that there's a benefit of taking HRT in terms of SCAD recurrence. That is also possible. There are two sides of the coin. It may make no difference. We don't know with absolute certainty. Because we don't know, but there is some data out there, and that data doesn't show anything, our view is that HRT isn't contraindicated in SCAD. It's not banned. As long as you are fully informed, and I'm fully informing you, as long as you are fully informed, and we have to recognise that there are other risks and things with HRT, and those that are not SCAD related, and those are things you should also talk about with your GP, family histories of breast cancer and so on and so forth. But from a SCAD perspective, we don't think HRT is banned if you have intrusive menopausal symptoms. We tend to prefer the body identical forms of HRT, those are the patches and gel type ones, rather than the synthetic ones, because they have a slightly lower cardiovascular risk profile. What we really want is more data, and then we can come to you, rather like in the clinical trials, and we'd love to do a clinical trial in HRT. And I do hope we can come back with firmer data, but that's roughly where we stand on that at this time, and we can talk about that a bit more. Chest pain after SCAD is normal. Most people will experience some chest pain after SCAD, or some variations around that. Sometimes it's more palpitations, sometimes just a bit of tightness or breathlessness. It can be quite variable, but those symptoms are very common. In our experience, they're often worse with emotional stress or after a big day. I sometimes say to patients that sometimes what you see is you get patients who they have a good day, feeling really great, so they do loads. And then at the end of that day, they get post-SCAD chest pain and get hit for, punished if you like, it's a harsh word, for doing the big day. And then they can't do anything for 3 or 4 days because of the post-SCAD chest pain. And then they have another good day. And what we're trying to do, or trying to get you to think about, is on the good day, do a little bit less, but on the bad days, try and do something so that you can try and turn that into that, so that you're getting a little bit more and a little bit more exercise. But I think it's important to say that it's normal. It doesn't predict stuff. So recurrences occur in people that have no post-SCAD chest pain and people that have post-SCAD chest pain. It doesn't seem to be predictive. And it does get better in most people. There will always be some people that have a tougher time, but in most people, it gets better over time. In many people, it will fade into the background completely, but it takes longer than you want it to. We sometimes say it'll take 18 months to 2 years. So you will, some people will continue to experience some symptoms even after that. Maybe if you get something that happens, an infection or something that happens in the family or something like that, and it's like your old war wound that plays up again. But the most important thing is it's not a sign of badness, it's part of the new you, and hopefully it will get better with time, at least in most people. Psychological consequences of SCAD. Again, a lot of this is normal. It is very normal to have a grieving type response after a major health event. It doesn't have to be a SCAD, it happens with everything. It's like you're sort of almost grieving for the self that you were before that happened. And the important thing is that that's okay. That's part of recovering from a significant illness, and it's very normal. Some patients will have more extreme psychological reactions to having SCAD, and again, those are very understandable. And what I would say, first of all, this is something that we're quite interested in trying to learn a bit more about and trying to think a bit more about in terms of how we run our clinical service. This is something that is not yet mature in what we do. So we need to do some more work on this, and we recognise that. But if you are having significant psychological problems or consequences of your SCAD, sadly at the moment in the UK, waits for counselling are very long. And so what I encourage people to do is to get on the waiting list. If when your name comes to the end of the waiting list, everything is, happy and dandy, and you're sitting on the beach, watching the sunset, and no longer feeling or even remembering that you've had SCAD, great, cancel your appointment, somebody else will have it. But if you're on the waiting list now, it means that you have the opportunity that will come up if you need it. Going back to work is, generally speaking, a good thing for psychological recovery after SCAD. We want you to get back to the things that make you you, because that's how, if you like, the bit between the ears gets better. So if possible, go back to work, but think about phased returns, going back gradually, and talking to your employer about what they call reasonable adjustments, tweaks, little changes that mean that you can get back to that environment and hopefully, manage, if you've got some post-SCAD chest pain, make people aware of that so that you can manage what you do. And above all, try and avoid what I call the stress-stress cycle. So we know that there's a bit of a link to SCAD, between SCAD and emotional stress, but sometimes thinking about that can be incredibly stressful, right? And I think one of the important things is that the relationship between emotional stress and SCAD is not one-to-one. There's a lot of emotional stress out there in the world, and fortunately they're not all coming to my SCAD clinic. Even in the SCAD community, let's face it, there's quite a lot of stress that happens in life. And it doesn't invariably lead to SCAD recurrence. It's not like that. It's more a little bit about the general background. And so the main thing is, if something happens and it's a bit stressful, is not to get worried about that, because that's just stressful. And then you go up this, what I call the stress spiral, and you feel a bit more stressed because you're feeling stressed, and that's really quite stressful, so you feel even more stressed. And then As with the post-SCAD chest pain side of things as well, coming up with your own strategies, coming up with your own ways of thinking about things. Not everything that makes people feel better is in tablet form. And so coming up with things that work for you is, generally speaking, a good thing if it makes you feel better. So, SCAD UK Clinical Services for the last -5 minutes of my talk. You've already heard, more capacity is needed. At the moment, we need more SCAD specialist services in more geographical places. It is critical, in my view, that all SCAD services remained networked for research and education purposes. And one of the things we want to develop is a UK-wide multidisciplinary team group so that we can bring everybody who's interested in this area together and we can discuss those ambiguous cases, those SCAD mimics and things that we were looking a little bit about earlier on. We need some money to do that, and we have been, believe me, working very hard to lobby for this. It's tricky in England. NHS SCAD clinics in England remain unfunded, and it's very difficult to get specialist funding. SCAD service largely runs in Leicester. We are excited that we have some new services beginning. So in addition to Dr. Al-Husseini's London clinic at Chelsea and Westminster, that some of you will be looked after by her in London, so she obviously is very familiar with SCAD as well. We are starting a new London clinic at the Hammersmith Hospital with Dr. Rasha Al-Lami, who's here, who is a completely brilliant female interventional cardiologist from London who has a brain the size of multiple universes, and hoping to be able to tap into it because mine's quite small. But she is excellent, and I think we'll hopefully be running a really good additional service there to try and increase capacity in London, in and around London. We are very, very excited that thanks to a lot of work by Liz Newbeck, who's here and you'll be talking a bit later on, and also our Scottish patients. I'm just going to put a little call out. There was a particular Scottish patient who's been very involved in this from the Scottish Islands. I'm not going to name her, but she knows who she is, who has been incredibly involved in lobbying to help us to get this. But this is actually funded as a pilot, so it's not it's not sort of secured yet, but we have now got a funded Scottish pilot. And I'm going to just introduce you to Dr. Anne Scott. Just to say a little hello from the Scottish SCAD Clinic.
Thanks very much, David. Before I speak about Scotland specifically, I'd really like to thank the Beat SCAD trustees for the invitation to come along and to congratulate them on everything you've done over the last 8 years, supporting patients, fundraising, and helping out with David's research and putting up with him speaking too long on any given occasion. That's really impressive. I also want to give a big shout out again to Liz Newbeck, who really is the impetus, alongside the patient pressure that's gone to Scottish Government to make this part of their priorities. Liz Newbeck has been the impetus for the clinic in Scotland. In Liz's own words, she says she stalked me till it happened. That is a quote. And also just to David and Liz for being motivated to provide care closer to patients' homes. I travelled from Edinburgh yesterday. That's one of the southernmost cities in Scotland, and it took me 6 hours. For our patients from the north of Scotland, in rural areas, you could double that. And for patients from the islands, it might take them more than a day to get there. So it's really important that those patients have some access. It is just a pilot project at the moment. It's just got some seed funding for 2 years. For the first year, David is attending in person for every clinic that we do as we develop our own local expertise. And in the second year, he will support us sort of virtually as we envisage moving forwards with the network that David's described, and hope to work in tandem with people, all the way across the UK. I'd like to say to the Scottish patients, I'll not get you to stand up, but bear with us. All new services have teething problems and there'll be some snagging to be done. But we've done 2 clinics so far, and our feedback from both patients and clinicians has been really great, actually. And then finally, I'd like to thank all of the delegates. Several of you have already shared your stories with me, and it is a real privilege to be able to be here and to learn from your sort of, pooled wisdom of your lived experience. So thank you again.
So very exciting, and my Scottish accent is in progress. Seeing Welsh patients in the clinic remains a challenge, and Northern Irish patients. I am pleased to say that following a pause where we were briefly not permitted to see Welsh patients without written confirmation of funding from the Welsh Government, that the far-sighted management of the hospital in Leicester have agreed that at least for the next 6 months we may see Welsh and Northern Irish patients whilst we continue to lobby the Welsh and Northern Irish governments to notice that they have SCAD patients who need to be seen. So that's good news. It does remain work in progress. It's always challenging, the politics of it. Irish and European patients, again, I'm mentioning this in case they are watching the video, that we do, again, happy to see these patients if they would want to be seen in the clinics. There is a small fee. I don't do private practice, as many of you already know, but there's a small fee that the hospital charges for those patients to allow them to access the service, and then we see them as an extra so that they're not taking up anybody else's space, but we can still see them. There is also potentially some contacts in Ireland. I think Catriona sees patients, so again, that's on the BeatSCAD website if you're from Ireland. Referrals, just cantering through this. We do need a referral of some form. We're happy to be as permissive as possible. It can come from your GP, your cardiologist, your rehab professional or nurse. Any of these people can send it. There's a letter, an email, and there's also the choose and book system. And in terms of clinical teams, we hope that we will be able to develop this MDT process soon. But if you are worried about a SCAD patient, pick up the phone. Phone me. Okay, and look at this book chapter, which is targeting medics. I know this isn't a medical audience, but there might be some on there, so that's for them. And this is obviously a kind of blur of names, and I'll probably have missed somebody off here, but the main message here is that SCAD, clinical care and SCAD research involves loads and loads of people, as does BeatSCAD. And they all give their time, you know, my own clinical team, who are kind of hiding at the back there, all give way beyond, you know, above and beyond, and are completely amazing at supporting the clinical service as well as the research. So.